We are going to discuss a case of 66-year female who presented with liver lesions. Biopsy from the liver lesion has been attempted twice, but it was negative. So she is sent for a PET-CT scan to know the extent of the disease involvement, a possible diagnosis and a proper site to do the biopsy. This is a whole body MIP image of the patient which shows physiological FDG uptake in the brain. Liver we are seeing pathological lesions and mild uptake in the spleen, and all these tracer uptake what we are seeing is the bowel loops which happens in diabetic patients. Moving on to the transaxials, we see multiple liver lesions which are FDG avid. Apart from that, we see a lot of lymph nodes, the supradiaphragmatic lymph nodes with areas of necrosis, abdominal and retroperitoneal lymph nodes, a few pelvic nodes, and supraclavicular lymph nodes on the left side, making it a stage 4 disease. So coming to the most important point, there is this intense FDG uptake in the liver on the fused PET-CT images, but the corresponding CT images do not show any lesion in this area. Similarly, we also find intense FDG uptake in segment 5 of liver over here, but there is no definitive lesion in this region except a few ill-defined lesions. And there is this large necrotic, centrally necrotic lesion with peripheral FDG uptake. This is the arterial phase CT scan of the same patient. The importance of this scan is it highlights all the smaller lesions which were not seen on the venous phase CT, but still they are avid on PET-CT scan. As we can see, a tiny lesion over here, other lesions in segments 7, 5, and 6. So it highlights the importance of PET-CT. In spite of their morphologically evident, not being evident on the venous phase CT, they were intensely FDG avid on the PET scan. The other important thing is the centrally necrotic area has got a peripheral enhancing area in the largest lesion in the right lobe. So the highlights of this case are the possible diagnosis in this case being metastatic multifocal hepatocellular carcinoma versus intrahepatic cholangiocarcinoma. The other important clue which the scan gave us is guiding the clinician to the site of biopsy. Initially, even though twice the biopsy was attempted from the liver lesions, it was negative. Now they have to do the biopsy from the periphery of the lesion where there are viable cells which are FDG avid. The central necrotic portion is not FDG avid. So hitting the needle in the center portion doesn't yield any positive results.